From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
Hello and welcome to our listeners around the world. You're listening to JAMA Neurology Author Interviews. Thanks for joining us. My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center. Today, we are discussing anticoagulation after ischemic stroke secondary to atrial fibrillation. Dr. Stephen Warach is joining me today. Dr. Warach is a professor of neurology at Dell Medical School of the University of Texas at Austin. He is also the Regional Stroke Director for Ascension, Texas. He has made impactful contributions to stroke diagnosis and treatment, including utilization of diffusion-weighted MRI in the diagnosis of acute ischemic stroke, as well as contribution to the adoption of tenecteplase as standard of care for acute stroke thrombolysis. Dr. Warach was the recipient of the 2024 David G. Sherman Lecture Award from the American Heart Association for his work in stroke neurology. Dr. Warach, thank you for joining us today.
Thank you, Dr. Armand. I look forward to talking to you.
Now, we're discussing the work of you and your colleagues titled Optimal Delay Time to Initiate Anticoagulation After Ischemic Stroke in Atrial Fibrillation. Can you take our listeners across the landscape of what is currently known about ideal start time for anticoagulation after this type of stroke?
I want to actually take us back about 40 years because this is a long and interesting and curious story. In the 1980s, there was a lot of debate in the literature about when to start warfarin for secondary prevention of stroke after atrial fibrillation. And it was based on relatively small cohorts, retrospective studies, a lot of debate. And this was when I was a medical student and neurology resident, so this was a really prominent discussion. And, atrial fibrillation is fairly common. It's getting more common. Current estimates are 20 to 25% of ischemic strokes are due to AF. But it wasn't until the first American Heart Association, American Stroke Association guidelines in 2006 that a comment was made about when to start. And this was not based on randomized data, just expert consensus. Well, then the direct oral anticoagulants came along around the early 2010s, showing that they were more effective and safer than warfarin. And that whole landscape changed, and there was recognized to be a need for randomized studies with the DOACs to answer the question, can we get any more specific than the first 2 weeks?
Right, exactly. And it seems like definitely what we were practicing was based off of the vitamin K antagonists and heparin especially. And we're going to use the term DOAC, direct oral anticoagulant, here in our discussion. Tell us more about the inspiration of your study and how specifically you're going to determine this optimal time start. Because even though many of us may feel a little warm and fuzzy, I think maybe not too warm and fuzzy about when we start these DOACs, there's always that question of, are we doing it too late? Ooh, are we doing it too soon? And I think, we got comfortable with 2 weeks, 14 days, that's it. But where did it start for you?
As a matter of fact, it started from back when I was in training because we would debate this all the time, and we're still debating it. So the opportunity came along. We were fortunate, my colleagues in Texas and I across other institutions, to get funding from the state of Texas to do clinical research, clinical trials. So my thought was, okay, we want to involve our hospitals. What's the problem we face every day that would be relatively simple to study, but an important question to answer? As you described my background, anticoagulation trials is not something I've done before, but this seemed to be one that we could manage because it's so common and it's a decision that we make all the time and we should be able to answer. Now, the second part of this approach was a novel statistical approach, response adaptive randomization using a Bayesian design. If you're interested, I could talk more about that as well.
Now, why don't you tell us about your methods and get into that?
Yeah, so the concept of response adaptive randomization it's been used in clinical trials, but it's been used in the context of comparing different doses of the same drug or comparing different drugs. So we thought, and the basic premise is using the Bayesian statistical models, you could take the result on individual patients as it comes out and then feed it back into the model, and the model then adjusts the probabilities of which group you randomize to based on which arm is looking more favorable or less favorable. So it's potentially a way to make the trial more efficient, get an answer as quicker than possible than just having fixed cohorts of equal size among the groups. We took this idea and instead of the dose of the drug, used the time delay as sort of the time dose. And we, with help of our statistician colleagues, we designed the trial that way.
You looked at a cohort of individuals who were diagnosed with mild to moderate ischemic stroke, secondary to non-valvular atrial fibrillation. And how did you kind of break up the time frames of anticoagulation start within those 14 days?
Yeah, we specifically wanted to avoid the TIAs and mildest strokes because thought there really wasn't a lot of equipoise there. People were already doing that. It seemed very low risk. And then we avoided those that were considered high risk, which, consensus is and guidelines say, well, if they've got significant hemorrhagic transformation or uncontrolled hypertension or other reason why they're in a high risk category, current guidelines say wait for more than 2 weeks. So we wanted to get what we thought were the sweet spot in most of the strokes, eliminate the mildest, eliminate the most severe, and then within that cohort, randomized not just to early or late. We wanted to see if it could be more precise, because early and late could be variably defined, and it has been in other trials. So we chose 3 days, 6 days, 10 days, 14 days as our cohorts. As the trial went on, we expanded the first cohort to 3 to 4 days because we were getting feedback from sites that they weren't ready to make the decision sometimes before 3 days, because it wasn't 3 days from admission, but 3 days from stroke onset. So that's how we started. And the initial randomization was equal across the 4 groups. And then as we went along and got our results, the statistical model did adjust to begin to favor certain groups.
Mm-hmm. Now, before you go into the results, did you have a hypothesis of what you thought would happen, especially given the feedback from the sites not being ready to make the decision by 3 days? What did you kind of think would happen in terms of your results?
My sense is it would have been somewhere in the early range would have been more favorable. I mean, you've had this experience treating strokes. Opinions are all over the map, really. And it really depends on people's level of comfort, familiarity with it. What do you do if there's a little bit of hemorrhagic transformation, but not a lot?
Right.
So even at our own center, I had to talk to my guys that, look, we really don't know. But you had to be comfortable with the patient potentially being in either of the extremes. And then, that may have resulted in some biased selection, we acknowledge. But my hypothesis was that earlier, I don't know if it would be 3 or 6, but earlier would be better than later, particularly with the direct oral anticoagulants, the DOACs, because most of the biases in the field were based on heparin and morphine. And this is a different ballgame now.
Right, exactly. Now, what did you find?
So our primary endpoint was the composite endpoint of ischemic stroke, systemic embolus, symptomatic ICH, or other major systemic hemorrhage. So we used as our primary endpoint this composite endpoint, that is something bad happening relating to anticoagulation or lack thereof. And so at the end of the trial, we found that the earlier cohorts had a higher probability of being the best cohort. We didn't reach our statistical thresholds, we didn't prove it, but the first cohort, starting randomized within 3 to 4 days, had a 41% probability of being the best among all 4 of the cohorts. There was a decreasing probability as we went on to the later cohorts. We found that in that earliest cohort, there were no examples of patients developing ischemic stroke. And analogously, at the 14-day starting point, there were no cases of developing hemorrhagic transformation. So with the in-between groups that had both examples of ischemic and hemorrhagic stroke.
Did you find that there was a clear distinction as to when the optimal time to start anticoagulation with DOACs would be based off of your data, meaning day 6 versus day 10, in terms of clearly adverse events occurring versus not?
Our original design was a 1,000-patient trial, but because of funding limitations, decreased enrollment rates confounded by conducting the trial during COVID, early on we redesigned it to 200 patients. So we were underpowered to really test our initial hypothesis of finding one of those 4 groups, meeting the criterion for being the best. We did, however, find that on arm 1, which is a 3 to 4 day, there was a 41% probability of that being the best among all 4 arms. Cohort 2 was 26%, cohort 3, 17%, cohort 4, 15%. So if one looked at early being within the first 6 days, that was a 67% probability that that's better than starting it later on this composite endpoint.
Right, exactly. So in this particular analysis, earlier is better when we're saying starting DOACs, but specifically for this, where do you see your work going, right? Because I feel energized and motivated by this work to kind of continue on and get more granular with it so everyone can become warm and fuzzy as we did years earlier.
I would interpret these data in the context of some other randomized trials looking at similar questions. And I think it was probably around 2017 that not only was when we were designing the study, but colleagues in Europe were also designing randomized studies. In fact, there were 3 trials that have been reported addressing the similar question. They each had their own unique design. None of them proved that earlier was better than later, but all the data seemed to indicate either non-inferiority or higher probabilities that earlier was later. And as I said, earlier and later defined differently in each trial. So I'm with you that, which is why we designed it the way we did, that I'd like to be more granular. As you know, if you don't start something like an anticoagulant before the patient leaves the hospital, it gets a little bit out of your control whether they're actually going to be starting on the prescribed day. So it'd be wonderful if we knew it was safe and effective to start everybody, within 3 days, within 4 days before they left the hospital. There is more work to be done. I think our trial called START, which is the first randomized study of this question on a U.S. population, that in the context of the 3 recently published European trials indicating at least non-inferiority, I think it should make people comfortable that within at least this cohort of not the most severe and not the most mild, that earlier is better. Where that cutoff is it 3 days, is it 6 days? Our data show it's trending toward the earlier 3 to 4 days, but it's not enough to claim statistical proof yet. And then the bigger question is the more severe ones, the higher risk. I think these trials need to be redone, if you will, for the high risk population. Total MCA territory, patients with hemorrhagic transformation. And a lot of these AFib patients, they tend to be bigger strokes, bigger cardiac embolism. A high percentage of them undergo thrombolysis or thrombectomy, which may predispose to some degree of hemorrhagic transformation. We don't really have any data on the safety of starting anticoagulation early if there is a minor amount of hemorrhagic transformation on the follow-up scans. The more one does this, the more comfort one has, but that's not a statistically reliable conclusion.
We take every case differently and individualized, per se, in terms of weighing the risks and the benefits. Any closing thoughts, Dr. Warach?
I think the START trial, our results should be viewed in the context of the other randomized trials that have come out on the similar question, all pointing in the direction that earlier is more favorable than later in balancing the risk-benefit of recurrent ischemic stroke versus serious hemorrhage. I will say that my colleagues and I, European colleagues, when we knew we were all doing these studies, had planned an individual patient pooling meta-analysis to combine our results from all the trials and all the subjects, and look forward to being able to present those results, and they may shed more light on this question.
Thank you so much for joining us today, Dr. Warach. I really appreciate your time.
Thank you.
I'm Dr. Cynthia Armand, and I've been speaking with Dr. Stephen Warach about optimal timing of direct oral anticoagulation after ischemic stroke and atrial fibrillation. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.